Welcome to Clyde Ellis Medically Speaking. Each month, we'll explore a variety of topics to help you better understand certain medical conditions and treatment options. Today's guest is Dr. Vijay Iyer, the Medical Director of Cardiology at Clyde Health. Today, we'll be discussing trans-aortic valve replacement and the benefit of this life-changing procedure. I'm Mike Hughes, and this is Medically Speaking. Dr. Iyer, thanks for joining us today.
Thank you.
You and your colleagues are part of the Gates Vascular Institute. Tell us a little bit about the GVI and why it's so unique.
The Gates Vascular Institute, as you well know, was really designed to be a center for cross-collaboration between the different endovascular disciplines and the surgical disciplines. It was also designed to be at the cutting edge of technology and research. And over the last 7 years, we have met up to that mark. I think we can confidently say that Western New Yorkers do not need to leave Western New York for state-of-the-art care in endovascular medicine, whether it be neuroendovascular, peripheral vascular, or cardiac vascular. I can tell my patients very confidently that there is absolutely no reason for them to seek care elsewhere, and we can pretty much provide everything that is necessary for their care right here at the GVI.
So one of the procedures that you guys are now performing is TAVR. So talk a little bit about TAVR, what it is, and who's a candidate for that.
TAVR, or transcatheter aortic valve replacement, was meant to be a endovascular approach to replacing the aortic valve. So this is a way to replace a patient's aortic valve without opening the chest. TAVR was initially started in about 2011 with an indication that was reserved for patients who were not good candidates for open heart surgery. Either they were too old or too sick, and these procedures were being done primarily through the femoral artery, or the vessel in the groin. Over the last 2 years, though, the indications have expanded, and now TAVR is available even for those patients who are deemed to be at moderate risk for aortic valve replacement. And the field is moving so fast that we are currently in a trial, and the GVI is one of the sites where we are taking patients who are at low risk, who are candidates for aortic valve replacement, and randomizing them to surgery versus TAVR. So in all likelihood, TAVR will become the state-of-the-art way of replacing aortic valves for pretty much everybody in the near future. There are still some questions about the long-term durability of this valve, which will need to be addressed with clinical trials. But essentially, at this point in time, if you ask me who is a candidate for transcatheter aortic valve replacement, the answer is almost everybody.
What types of ages, what's the age range of patients that you see? Is this something that's, your traditional baby boomer age?
So typically, aortic stenosis, or senile calcific aortic stenosis, is a disease that manifests itself in the late 70s and 80s. People who end up with aortic stenosis at an earlier age have a congenitally abnormal valve. When we talk about transcatheter aortic valve replacement, we're really talking about the senile calcific aortic stenosis patients. They tend to be older. Usually they tend to be in their 70s, 80s. The oldest patient that we have done a valve replacement is 102 years old. The youngest we've done it in is 60 years old. So the range varies. A lot of different patients show up who are candidates, but essentially they tend to be older patients.
You mentioned heart surgery before. What's the difference in recovery between your traditional open heart surgery, talk about opening up the chest, and then something like TAVR?
Right. So traditional open heart surgery can be done either with a midline incision or a small incision, but either way, the heart is put in a heart-lung machine, and typical recoveries can be 3 to 5 days in the hospital, but there's also the scar and the healing that goes, which typically takes a couple of weeks. With transcatheter aortic valve replacement, we are only doing a small puncture in the groin. This procedure now is being done under sedation, not general anesthesia. That means people actually go from the cath lab to the recovery room, and from the recovery room, they go actually back to the room that they came into in the ambulatory suites. Most patients are home within 48 hours, and within 3 to 4 days, are able to resume all activities.
So it's obviously a longer recovery, both physically. What about mentally, in terms of getting the patient back up on their feet and getting moving again? Do they have to go to cardiac rehab and things like that?
Most patients, if they were functional at home, go back home because there is really not a big duress from the procedure itself. If patients were very debilitated coming in, certainly they need to go to rehab for a period of time. But most patients we feel and find that are able to go back home and resume their daily activities of living within 48 hours.
talk to us a little bit about the GVI and the number of procedures that you're doing. I've heard that this is one of the sites where more of these procedures are being done than anywhere else in Western New York.
That is correct. So the GVI currently probably is in the top 1 percentile in terms of procedural volume for transcatheter valve replacement. Last year we did about 240 procedures, and this year we will probably exceed 300 procedures. So just to give you a sort of where we stand in the scheme of things, there are about 560 programs in this country that do transcatheter valve replacement, and any program that does in excess of 200 procedures a year puts them in the top 1 percentile of these procedural volumes. We, with our collaboration that we have been able to be pretty high volume. As a consequence, we are now in a number of cutting-edge clinical trials because of both our quality and the volume.
Talk about we talked about the patient demographic before, but how do you even know if you're a candidate for this type of surgery?
I think for most patients, it starts with their primary care physician detecting a murmur, or for them showing up with either heart failure symptoms or symptoms of fatigue. And they usually end up with their primary cardiologist, who will get an echocardiogram, which will show them that the valve has narrowed. Many patients have been followed. Now, this is not something that happens suddenly. It's a process. So most patients should be aware of a murmur and should have had echocardiograms. When an aortic valve is less than 1 centimeter squared in its area, is typically when patients tend to have symptoms and will be candidates for a valve replacement.
What if you're a cardiac patient before this? If you've had some sort of stent or some sort of replacement, some sort of open heart surgery, are you still a candidate?
Everybody is a candidate. As I said, in this day and age, even if you've had a previous bioprosthetic aortic valve replacement and you need a new aortic valve, we are able to put a transcatheter valve inside a bioprosthetic aortic valve. So, as I said, essentially anybody who has aortic stenosis in this day and age could potentially be a candidate. The only way to truly determine that is to be evaluated by a multidisciplinary team, as exists at the GVI, where they get an evaluation not just with the cardiologist, but with the open heart surgeons as well.
So for the people watching at home, they have cardiac issues, someone in their family has cardiac issues, what kind of advice do you have for them?
I think the first thing is for them to talk to their primary care physicians, and then from there, if they have established cardiologists, to actually talk to them. If they have any kind of valve issue, I would strongly recommend that they come and spend some time at the GVI with us in the valve clinic, because we are now able to come up with novel ways to deal with a lot of these problems with valve disorders. But most importantly, we are able to give them the benefit of a comprehensive evaluation for their condition that includes cardiologists, interventional cardiologists, heart failure specialists, and cardiac surgeons, all looking at the patient together. And that is the biggest benefit of having a multidisciplinary team.
Dr. Iyer, thanks for joining us today.
Thank you so much, Mike.
Thanks again for joining us on Medically Speaking. I'm your host, Mike Hughes.